still vote. Ann.
Thanks, Tom, for inviting me to speak on our efforts in the care centers to improve distress screening. To remind you, this is the NCCN definition of distress in cancer, a multifactorial, unpleasant emotional experience of a psychological, social, and or spiritual nature that may interfere with the ability to effectively cope with cancer, its physical symptoms, and its treatment. It extends along a continuum ranging from normal feelings of vulnerability, sadness, and fears to problems that can become disabling, such as depression, anxiety, panic, social isolation, existential and spiritual crisis. So that's the NCCN definition from their guidelines in 2007. The IOM also had a document in about the same time, 2007, calling for emotional distress. And most recently, the American College of Surgeons Commission on Cancer has a looming deadline, actually for us, in 2015 for psychosocial distress screening. So the Cancer Committee develops and implements a process to integrate and monitor on-site psychosocial distress screening and referral for the provision of psychosocial care. So that's a relatively short deadline coming up, and we'll talk more about that. In this particular standard, they're looking at the timing once at minimum at a pivotal medical visit using a standardized validated instrument, evaluation and referral by the team for moderate to severe stress, documentation of that, and again, January 2015. So ASCO also has an emphasis on emotional distress screening. COPI, if I can remind you, is ASCO's Quality Assessment Improvement Program for outpatient oncology, and it involves a retrospective chart abstraction for evidence and consensus-based measures. We've used COPI here as a platform for performance improvement within the care centers. We initially had a baseline abstraction of 430 some charts, which I'm told is one of the largest North American abstractions for one institution. And distress assessment is one of these core measures that we think is important. And this was identified by care center physicians as a desired focus for performance improvement. So this is the body we call QSP, or the Quality, Patient Safety, and Clinical Practice Council, that's very active in the care centers. It's multidisciplinary. It involves nurses, physicians, pharmacists, and folks interested in quality. And the idea is to focus on clinical practice and patient safety issues within the care center network in alignment with all Smilow campuses and the healthcare system. And so this group looks at evidence-based standards for national benchmarking, looking at adherence to clinical standards, reviewing adverse events in the care centers, press Ganey, and looking at performance improvement strategies, most specifically to coordinate quality improvement activities associated with the care center quality platform. So this group decided that we wanted to focus on our ASCO COPI scores of emotional distressment. Here in 2012, those abstraction results showed 50% of Smilow Cancer Hospital patients had documented assessment of emotional well-being assessed by the second office visit. And in compliance in 2 of the 10 ambulatory sites was below 12%. This is shown in the next slide here. So here's Waterbury, our star here at 87%. Here's some scores for Greenwich, also in our network. This is COPI for fellows, doing some charts at the main campus. And here is the St. Rafe's campus, CCA and CCB, at 11% and 7%. We decided to focus on these clinics. And we decided to do this at the same time that ASCO started their Institute for Quality. So they had their debut program called the Quality Training Program. And so our group decided to put in an application to participate in this, and was chosen out of, I think, 14 total groups across the nation to participate. And this really is to give you an education on this idea of, Gary talked about science, lab science, we're talking about quality improvement science or implementation science. And there is a real science there dating back to William Deming, who was born in 1900 and really provided a lot of those principles behind what's been adopted by the Japanese and their lean strategies and so forth. So we were accepted to this program, and we decided to choose, again, distress management for the focus. And the two folks I really want to recognize in this work are Stephanie Bouya-Amport. She's there in the back row, and she's our quality and safety coordinator for Smilow and the Care Centers. And she and Diane Corgiulo, our Greater New Haven clinical program manager, went with me to ASCO in a series of face-to-face sessions and workshops, but also helped to coordinate this whole team, including Dr. Lundberg, Silber, and Tara, who's not on there, Dr. Harvey, who's one of the fellows who we got involved in this process, our nurses, social workers, advisors, and this was sponsored by Ruggiero and Kathy before Karen's time, but definitely Karen has been very involved. So as I go through this, I really want to tell you not only our results, but the story of how you do a quality improvement project, because that's important, I think, for what this particular project, but as we move forward. So step one, you have to map your flow. You have to understand what the process is. And this is informally referred to sort of swim lanes. This you may not be able to see: front desk, lab, PCA, MD, RN. And this is a flow map of how a patient gets checked in and assessed for emotional distress and where it happens. This is a group activity with those folks in the previous slide where everybody has yellow Post-its and you write down your different aspects of the flow and you come together and figure out how it all fits together, and then Stephanie creates this beautiful physio diagram that shows it. The second is what we refer to as fishbone diagram, this cause and effect. And again, you have this group and you have lots of stickies and you're really brainstorming about what causes low screening and intervention. Then you put all those stickies into a place and tally them up in buckets here, or as shown in the Pareto chart here. These are all of the different reasons identified, and this is how often they're identified here. And the top four causes are not enough time with patients due to volume or emergencies, lack of social work resources, lack of privacy and space, and that the patient's comfort level in talking about distress. So the next step is to develop that AIM statement, and we said, okay, by April 2014, we want to increase screening of distress levels to 75%. Remember, we were around 10% of patients seen in these two clinics in that pilot period. And then we were looking next to select our tool and identify our measures and start to implement. So this is the instrument that we selected. It's the NCCN distress tool. It's a color-coded scale between 0 and 10. Here are areas where you can check off things that are a problem for you, if it's housing or fear or physical symptoms. And we also added here a checkbox for I would like to speak with somebody about my concerns, or I do not wish to speak, and a place for the patient to sign, as well as a place for the doctor to sign. The distress tool, that paper tool, has a long history that I'm not going to go into. It's been around since 2003. This top reference refers to a meta-analysis looking at over 40 studies and lots of patients that looked at a pool sensitivity of about 80% and specificity of 70% if you use a cutoff of 4. So this is a tool that's been used for in lots of different settings and validated. We developed a cover letter here that was translated into, and actually the tool also translated in different languages. And this is an epic screenshot of whether or not, here's a permanent comments column, whether or not the distress tool was administered. And this was because we didn't want to give the patients a tool every time they came in if they were having multi-day chemotherapy or had frequent visits. So these are, I'm going to go in some detail over the process measures. And again, I think this is a learning process that you never get the perfect measure that you want, especially if you're dealing with Epic. So this is our first paper tool. So the measure here is % patients screened once using the distress thermometer. The patient population, all patients new and return in these clinics in that pilot period. There have been several pilots here on the main campus sponsored by Bonnie Indek and Matt Burke that really focus on new patients, and then another initiative in the transplant who looks at bone marrow transplant patient scores using that tool over time. Here's the exclusions: multi-day treatment, students will not get the tool every time. The denominator is the number of patient visits, and they're going to be counted every visit. The numerator, the number of patients screened with the tool once during the pilot, counts as compliant for each visit. So what does this mean? It means if you have a patient who's coming in for 3 days of chemo, cystotopicide, the denominator is 3. They're going to be counted for each visit. But if they got the tool once during that visit, they're going to be counted compliant for each visit. So that would be 3 out of 3, or 100%. The limitations here: the ability to look up every patient in Epic to get a unique count, that's why we do this, and staffing resources to collect data on busy days, and patient acceptance. So our second process measure was the % patients screened for emotional distress by the clinical team, same patient population, and here the denominator, again the same, number of patient visits, patients counted every visit, and the numerator, number of patients with distress level documented by the nurses in Epic. So that same patient comes in for 3 days of cystotopicide, so the denominator is again 3, but if the nurse documents the distress level twice, or on 2 days, it'll be 2/3. That's that calculation. And the data limitations here, currently the Epic report does not count unique patients. The outcome measure, very easy. We looked at Ganey. So the percentage, very good when you're answering this question: degree to which staff addressed your emotional needs. The limitations is just the lag time and the low number. And then this is the priority matrix to determine what our intervention was. So in this case, this is a sweet spot, high impact and easy to implement. So we chose the patient self-screening, so this is a real patient-reported outcome with the paper tool that's given by RN initially, and then the provider will review it during the visit, and then the nurse documents in Epic. And so we thought this was a good thing to start with because it addresses those issues that had been identified as barriers. Okay. This is, again, looking at these different tests of change, and any of you have done any quality improvement, you know that perfection is the enemy of quality improvement because you never get going. So in this case, you have a plan, you stick to it, and in real time you do tests of change to move along. And then step 5 is really looking at your findings. Okay. So this is the first measure that we talked about, the paper tool. And this is a deep dive in February on a daily basis. The blue line is % patients screened, and the red line is RN staffing. So first of all, we found out that snowstorms or natural disasters do affect quality improvement projects. And the second is that the staffing, we made a difference here in terms of having the PCA distribute the tool, and then our numbers started to go up. The second tool, the Epic, the nurses documenting, here's the percentage of clinic patients with the distress score in Epic. Prior to intervention, we were around 25%, and then this is where we implemented it. We went up to 40, and then the next chart shows you over the time that we did the pilot. So these are the 8 months that we did the pilot. This is the 8 months before. So we went from 20% up to 34%. One thing that we learned is that the nurses aren't documenting every form in Epic because by that count there were 423 unique patients, and we know that we collected 864 paper forms. Here's our COPE scores from 2012 to 2014. In these clinics, we had an increase overall, and actually had an increase overall in the whole network as well. And in terms of our outcome data, again, the quarter before and the quarter after we started the project, we went from 66% to 74%, with mean score here 90 to 93. And this shows you over time, this is where we started the intervention. And what you might not be able to see here is that we actually had increase here to 100% and 83%. So if you guys are familiar with the Ganey data, these curves are very, very hard to move. So this is really significant in terms of the patient satisfaction. Just a few slides on the analysis. I think this is really interesting, and this is where we're really starting to dive deep. So out of a total 860 some patients, again, about 30 news and 833 returns. Mild, if you look at those patients, 62% had mild distress, 20% had moderate, and 11% had severe, what we would term as severe distress. 10% didn't write a score down, and 3% refused it. This resulted in a total of 11% social work referrals. One of the things we were looking at is new versus returns, since Bonnie and Matt's concentrated on news. And there is significantly more distress in the new patients, 5.39, than returns, 2.5. And that if you remember that box where you were checking whether you were willing to speak or if you did not wish to speak, there was also a higher distress in those folks who wished to speak to somebody. Okay, what are the top? There are not really big surprises here in the top problems identified by patients. Worry, fatigue, sleep, pain. In the new visits, there were folks who were more interested in treatment decisions. That was causing a lot of anxiety. In the return visits, more physical symptoms, tingling in hands, feet, dry, itchy skin. In our mild distress levels, 0 to 3, again, some of these physical symptoms were prominent, but in the folks with severe distress, you start to see real depression and sadness coming out. So in conclusion, we did see improvement in the percentage of patients screened based on the tools collected and the RN documentation, our process measures, from around 10% to 52 and 69%. If you looked at the paper tools that we collected during this February to July period, we improved to 64% patients screened, so not quite that 75 that we wanted, but pretty good. And those improvements have really been sustained through our COPE scores, and we also saw a significant improvement in the Ganey outcome measures. I think that we always like to ask the voice of the stakeholders what they thought. The number of patients who weighed in, a mental health worker 1 year out, she said this is useful for, not for herself, she didn't need it, but useful for others who wouldn't speak up or who don't have the resources. A breast cancer patient follow-up said this is helpful, very important, easy, and she would like to see that in my chart. Our nurses said, well, this is challenging. It's challenging to give the tool to folks on arrival and have enough time to review it, especially for patients just seeing the physician. And some of the patients that they expected to be 10 were often less. And they also enjoyed finding out more about those who are not seen often, such as those folks coming in for monthly shots. Our physicians said that this tool definitely caught some patients, that it generated very good communication around distress assessment and management. And they noted that the distress level does not always correlate with the severity of disease. Sometimes it's related to non-cancer life events, such as losing insurance or a job or death in the family. So finally, lessons learned. I think it's really important to note that this is a patient-reported outcome and that we can incorporate that into our workflow, that we can use EPIC to capture and report on distress screening, and we are working on a better report and better tools for documentation. We had improvements in communication and patient engagement, and that our staffing does impact the tool distribution and documentation compliance. What are next steps? Well, this pilot I referred to the Commission on Cancer requirement. This has led to the development of a hospital and network-wide task force led by Stephanie and Bonnie and Matt, and championed by Karen and Ruggiero, Kathy Lyons, and myself. And with this goal to develop and implement an operating procedure for emotional distress assessment for all of our patients. And this pilot is also inspiring other QI efforts in the same vein to focus on other of those top problems identified, including pain, palliative care, identification of psychosocial and psychiatric resources. I would encourage anybody who's interested to talk to me or to apply for that ASCO program for the Institute of Quality. We've been able to present this work at the ASCO Quality Symposium and have been asked to submit it for publication as well in the JOP. Thank you.